when you're on the night shift, let's add another shift to manufacturing so we can make more money. And so we don't really put a big priority on sleep, but sleep equals health. And it's just amazing. I wish that I could shout from the rooftops to let everybody know that how important a good night's rest is. So let me get started with the PowerPoint. Okay, can you hear me now?
Yes.
Okay, good. So I'm Erika Mason. I guess I probably should tell you I'm a dentist by trade. I started at age 16 as a dental assistant. And I went to Virginia Commonwealth University and then went on to Virginia Commonwealth University to their dental school. At that time, it was VCU and MCV, so I have both names on my diploma. So when I was in my 40s, just last year, right, I started having some issues with my hands, but a colleague of mine also was trying to teach people, his colleagues, dentists, about treating patients that had obstructive sleep apnea, because instead of putting the mask on and having you wear what's called a CPAP, that's a continuous positive air pressure machine that blows air down your throat, we can make a dental device that you wear in your mouth instead that opens that airway and you breathe on your own with your own air. So luckily I had started treating patients with that when both of my thumbs started giving me issues. I had osteoarthritis in my 40s and ended up having 4 thumb surgeries. The recovery is 6 months per thumb, so you can do the math. That wasn't very fun. So luckily I sold my dental practice and continued doing just sleep. And it is pretty fascinating because I change people's lives. And when I did a filling, great filling, doc, but I didn't change people's lives. So this is so rewarding for me. So let's talk about some sleep. So when we sleep, we should cycle through 4 stages of sleep every 90 to 120 minutes. So there's 4 stages, N1, N2, N3, and then REM, which is rapid eye movement, or our dreaming stage of sleep. And then we should start doing it all over again. So these are the 4 cycles every 2 hours. So let's talk about N1. I call it the twilight. It's somewhat in between you're asleep or you're awake, okay? Like in maybe a few minutes, some of you will start dozing because I'm boring, and you'll probably be experiencing N1 sleep, okay? When you're driving drowsy and you should pull over, but your head keeps nodding, you're in N1 sleep. It's pretty scary. But if we look at the wave patterns of our brain, we're actually sleeping. It's only about 5% of our sleep, and so then we should, as our eyes close, we should go into the second stage of sleep, which is the majority of our night's rest, and that's called N2. And just for cocktail talk, you can brag about, oh, did you get into N2 sleep and have spindle fibers and K complexes? Whatever those mean, okay? Those are the 2 things that are on an EEG, which is the brain activity of your brain, that verifies that you're in that stage of sleep, N2. N2 is the majority of our night's rest, and it's kind of boring sleep. We're just resting. Maybe we might have a little memory consolidation, but for the majority of it, it's just that our body is resting. So that's about 50% of our night's sleep. So the next stage of sleep is N3, And this is a wonderful stage that a lot of times we don't get into, especially if we have we're a light sleeper and you hear a dog barking, or you have a train go by, or a bed partner is snoring or coughing. It might wake you up out of this deepest stage of sleep. Most children, this is the majority of their sleep. So if you have grandkids and stuff, this is where that toddler will fall asleep, and you can pick them up and carry them to bed, and they're like a wet noodle. So, and then if you think back, if you had your own children, when they became a teenager, you thought that they were very contrary or obstinate when they were a teenager because it was hard to wake them up. Well, most of the time, they're in that deepest sleep of N3 and have been there for hours. And so, of course, it's the deepest sleep. So if you're trying to wake them up, they have to go from N3 to N2 to N1 and then wake up. So it's a really deep part of your sleep. But it's very important for quite a few things. The first thing is these glial cells start moving because of the electronic brain activity makes them move. And when they start moving, they move your cerebral spinal fluid in your brain. And so we call it a brain washing, not the brain washing like you're being brainwashed and being interrogated. It's about a healthy thing. And so these fluids are washing around from the glial cells, expanding and contracting, and all of a sudden those toxins that are in our brain, and one especially that's important, are called the beta amyloid proteins. When people have Alzheimer's or are starting with some cognitive decline and dementia, they might have a buildup of these beta amyloid proteins, which aren't getting washed away very easily, especially if they aren't getting into N3 sleep. So when my mom was alive, she used to say, "Oh, I have cobwebs in my head." And so if you could have an incident that you're not sleeping that well, but you have kind of brain fog when you wake up that morning, you're having trouble concentrating or focusing, maybe you didn't get your brain washed the night before. But N3 also is where two of our drugs that we have on board just naturally, and how we make them and they are secreted to our body, are dopamine and serotonin. And those two drugs are wonderful drugs to have on board. But if we're sleeping and then we get nudged out of N3 and come back into N2, we kind of miss out on that. It's also where we take our memory and put it from short memory into long-term memory. It's also where our hormones are secreted. So some men sometimes have low testosterone because the N3 is where your hormones are secreted. So you might have low testosterone and also end up having erectile dysfunction. For women, our hormones are lessening, and so we don't have a word for that, but it's important for us to have progesterone, estrogen, estradiol, and testosterone as well. So then we should, after N3, we need to go into REM, and that is, it's using the term rapid eye movement, and that's when we are dreaming. And so it is not like any of the other three stages of sleep, N1, N2, or N3. So it's very different. And that's because the first thing is you have this movement of your eyes back and forth, and so it makes this wave pattern so that, like if you were in a sleep lab, that they would know that you're definitely dreaming. The other thing that when we look at the EEG, your brain looks exactly like you were awake. So that's why we dream so vividly in color, and it seems like it's very, very real, because it is. But for our bodies to protect ourselves so we don't act our dreams out, we actually paralyze our bodies so that we don't act our dreams out. So if we're dreaming about running through a field and jumping over a brook, we aren't jumping out of bed and cracking our head up on the nightstand and hurting ourselves. So most people don't really know about the paralysis. Well, oddly enough, the paralysis comes from vitamin D3. Okay, how many of you take vitamin D3 on a regular basis? Absolutely. That is a wonderful supplement because we get it from the sunshine. We can't get it from any foods because that's D1 and D2 that you could get from green leafy vegetables or milk or dairy products, and those help your bones. But D3 is the sunshine vitamin. But if you look at the molecular structure and take one carbon off, that's the drug that actually paralyzes us. It's called acetylcholine. So this rapid eye movement, that acetylcholine release, we have an increase of our body temperature and we have mixed brain waves. So if that acetylcholine doesn't have a big storage tank of the D3, your dreams are going to be very short, and that you don't have enough D3 to keep you paralyzed, so it's very short acting. And so I studied some with a neurologist who met and treated some Parkinson's patients, some MS patients, and some fibromyalgia patients. And they found that all of their D3 levels was very, very low. So when she got their D levels up to a common goal, so when you take some blood work and have your blood work tested for D3, it could be anywhere from between 30 and 100 points from your lab work. That 30 to 100 is 70 points. That's a pretty wide scale of what is considered normal. So she found that if we get the patients to getting their D3 levels between 60 and 80, that all of a sudden those Parkinson's patients' tremors were less, that their hands were a little more steady. With the MS patients, that they didn't have the muscle spasms that they suffered from with the MS. And the fibromyalgia patient didn't have as much pain involved with their multiple sclerosis or the fibromyalgia. So she said, there's something to this. So we had been taught that N3 is where we tend to repair and heal our bodies, but actually it also happens when our bodies are extremely still and paralyzed, because there's probably certain muscles and certain joints that can benefit from not moving so that they can have that healing process happen. So if we have a good storage tank of N3, then we can dream a little longer and allow our body to heal and repair. But the other part of the other part of REM, is that we're paralyzed. And that can be kind of a bad thing, because when we're paralyzed, we aren't using the same muscles to breathe that we are in 1, 2, or N3. We're using just our diaphragm, kind of like being on a ventilator. And so the brain can't wake you up and say, roll over or take a breath, if in fact you're paralyzed, because we're using only that diaphragm to breathe. So sometimes people really struggle, especially on their back, if gravity's going against them and they're diaphragmatically breathing and dreaming, if they're not getting enough oxygen, that could be a problem. So this is kind of a big portrayal of the whole sleep cycle for the whole night. So you have N1, N2, drop down into N3, and then go into REM. And that might be a 10-minute window of a dream. And then you should do it again in another 90 or 120 minutes. But then that dream will be like maybe 14 minutes, 15 minutes. And then you'll go through the cycle again, and 1 and 2 and 3, and then go into dreaming, and it's a little bit longer, maybe even 20 or 21 minutes. And then in the wee hours of the morning, after you've gone through that 4th cycle, then that's the longest dream, and then you usually wake up out of it, and that's when you remember your dreams. The other 3 dreams, you might have woken up and might have remembered them at the moment, but when you fell back to sleep, you aren't going to remember it the next morning. A lot of my patients say, I don't think I dream at all. And I say, well, you wouldn't be sitting here if you didn't dream. So even though you might not remember your dreams or not even are aware that you're dreaming, if you're sitting here, you're dreaming, okay? But sometimes it has to do with these stages or cycles of your sleep. So there's over 90 sleep disorders that a sleep physician needs to know about, okay? Obstructive sleep apnea is one of those, and that's the only one that I treat. But there's others that are like insomnia, sleepwalking, sleep talking, sleep eating, sleep driving. These are pretty weird things that people can do, but sometimes people will, like, I was hearing about this one patient and she said, I just can't lose any weight. And the doctor says, do you think you're snacking at night or eating at night? She said, I don't think so. But then she started paying attention, and the next morning when she would get up, she would find that she had taken a box of something out of the refrigerator or freezer and actually eaten some of it frozen because she was cracking some of her teeth. So, I mean, all kinds of crazy things. And then there's a thing called restless leg syndrome that makes your legs kind of feel like they're creepy crawly and having ants or bugs running up and down them. And so if you move your legs, that makes them feel better. We also have REM behavior disorder, and that's that you don't have that acetylcholine paralyzing you, and you act your dreams out. And that's a bit scary. And then we have what's called parasomnias, and that's kind of back to the sleepwalking and talking, also maybe some night terrors, nightmares, things like that. And then there's narcolepsy. And narcolepsy is that during the day, all of a sudden you can just fall asleep, but you immediately go into a dream. So kind of unusual things. So sleeping issues could start with snoring. Okay, snoring, I'll go on here, snoring isn't benign, okay? We always, or a lot of us, laugh and kind of snicker about people that snore, okay? And yeah, grandma so-and-so, she could peel the paint off of the room, right? But what happens is her husband used to snore, but he doesn't anymore. Now he stops breathing instead, okay? So this is what is a depiction of what sleep apnea is. When you have an airflow coming down the windpipe, but then the tongue or the soft palate of your throat blocks that airway and it restricts it. So there's a video here that I'd like to play for you that kind of explains this.
If you have obstructive sleep apnea, your breathing pauses for brief periods while you're asleep. Normally, when you breathe in, air flows in through your mouth and nose and down your throat, also called the pharynx. Air then flows down your windpipe or trachea, spreading through a tree-like structure of smaller tubes into your lungs. Each time you breathe in, negative suction pressure pulls the soft tissues in your mouth and pharynx inward. The muscles in your pharynx respond by pulling the soft tissues outward again, which keeps your airway open. When you sleep, it's normal for the muscles in your mouth, tongue, and pharynx to relax slightly, but not enough to block your airway. If you have obstructive sleep apnea, the muscles of your mouth and pharynx may relax too much. Your tongue drops onto the soft tissue in the roof of your mouth, pressing it against the back of your throat. This completely blocks the flow of air into your lungs. The lack of oxygen in your lungs wakes you up. You may gasp for air to re-establish airflow before falling asleep again. The cycle of apnea and waking up may happen many times at night, preventing restful sleep. Factors that may contribute to obstructive sleep apnea include obesity, because more fat may be present in the walls of the pharynx, a small or receding jaw with a narrowed airway, loss of muscle tone in your pharynx due to aging, and swollen tonsils. Common symptoms of obstructive sleep apnea are snoring, morning headaches, chronic daytime sleepiness, fatigue, irritability, and impaired concentration. Left untreated, obstructive sleep apnea may lead to complications such as high blood pressure, heart disease, irregular heartbeats called arrhythmias, stroke, and diabetes. Your doctor may recommend lifestyle changes to treat obstructive sleep apnea, including losing weight, sleeping on your side, not smoking, and avoiding substances that can make you sleepy, such as alcohol and sedatives. For mild or moderate obstructive sleep apnea, an oral appliance may keep your airway open. This device works by pulling your jaw forward and moving both your tongue and the roof of your mouth away from the back of your throat. The most common treatment for obstructive sleep apnea is a continuous positive airway pressure, or CPAP machine. This machine pumps air through a tube into a mask that fits over your nose, or both your nose and mouth. The mild air pressure of the CPAP machine helps keep your airway open, enabling you to get a deep, restful sleep.
Okay, so that's a pretty good concept of what's going on about sleep apnea. And I bring this to your attention just because it is an epidemic in our country, but it's also around the world. And the thing is, 80% of patients have not been diagnosed. So basically, it is 1 in 5 people have sleep apnea and don't know it. And then, if you look at the overall male versus female, it's a male-dominated disease. 3 men to every 1 woman, until women have reached menopause. And all because of our hormonal changes, then it becomes 1 to 1. That's pretty mind-boggling for me to wrap my head around, just because of our hormonal changes. Our airway and our muscle tone changes so that we have this collapsing and problem with our windpipe and our airway. But some of the things that it really has problems with is, the first thing is, like now, some primary care physicians are trying to screen some people that even in their 30s, if they're starting to have high blood pressure issues, then they send them for a sleep study. if somebody starts having a flutter or a problem with atrial fibrillation or AFib, the cardiologist now is sending them for a sleep study. This is a pretty young disease. It's only 33 years old. And so we didn't know that all of these complications are linked to sleep apnea. And years before, we used to think, oh, well, grandpa had a heart attack, grandma had a stroke, so I guess I just been given that bad genetic trump card, right? Well, no, nowadays we can actually change that trump card to actually preventing a stroke or heart attack by treating your sleep apnea early on so that it actually doesn't get that bad and that your heart doesn't have to work so hard. So the questionnaire that I have over on the table is this same questionnaire. So it's called the Stop Bang questionnaire, and it goes through some things like asking you, do you snore? How tired are you? Has anybody observed you stopping breathing? Do you have high blood pressure? Is your body mass index greater than 35? Are you over the age of 50? What is your neck circumference? And this says 40 centimeters. For men, it's 17 inches, and for a lady, it's 16. And then, since it is male-dominated, you get an extra point if you're a male. So if you add these up and have an answer yes to 3 or more items, you have a pretty high risk of 89% accuracy that you have sleep apnea. Now, I'm not allowed to diagnose because I'm a dentist. I just work under the authority of the sleep physicians, but it doesn't take many of these answers to yes to know that you might be having a problem with sleep apnea. So here's some famous people and celebrities who have had obstructive sleep apnea and died. Judge Scalia, that was on the Supreme Court, he was in Texas and had gone hunting, and they came in and saw that his CPAP machine was on the bedside table with the mask hanging there ready to be put on, but he had deceased in his sleep and never put it on that night. There's, Tim Russert, John Candy, Reggie White played, was in the National Football League, and so he died from sleep apnea. So his wife has had a pretty big campaign trying to get people to understand that this is a problem. And then different people like Jerry Garcia, Regis Philbin, and Carrie Fisher. So, it really doesn't mean that certain people have it or don't have it. I do try to tell patients there's not a look for sleep apnea. I treat a lot of very slim people that don't have a body mass index other than an 18, 19, or 20, and they still have a tiny little airway or windpipe. But some of the symptoms are that you're sleepy, you're tired, you have some memory issues, it's hard to lose weight, it's hard to regulate either your diabetes or your blood pressure, and that you might have some weight issues. And I got ahead of myself. People don't have a look, but they do have symptoms. But a lot of times we'll say, well, if you're carrying a little bit more weight, then the propensity of having sleep apnea might be a little bit higher. So there's another questionnaire that we look at a lot, and this is really more of a insurance company thing, that they want us to answer these questions of how sleepy or tired you are. Well, some people aren't very sleepy or tired. They just, they have energy, but they don't sleep very well. But it doesn't mean that they are napping throughout the day or extremely sleepy. But, so, again, you can give yourself a point for what is the probability that if you were sitting quietly reading, would you be able to doze? Moderately, absolutely, or slightly. Same thing with watching TV. And so if we add these up, sitting in stopped traffic, or actually talking to someone, lying down to rest if you had that opportunity, riding in a car as a passenger and you aren't the driver for more than an hour, would you doze? What's the likelihood? So if some of these get over, you can answer it, and it adds up to 10 or above, then absolutely you are pretty tired and sleepy and you might have an issue. So we talk about being tested. That's pretty easy. There's these different little things that you put on your body that is a home sleep test, or there is another test that you get all hooked up to all these wires, and that's where we actually know what stages of sleep you get into, and gives us quite a bit more information, but that's not necessarily what you have to do, because you could go back and have one of these is like a little watch, and then one is this night owl, is this little tiny thing that we just wrap on your finger, and then under the ResMed AirView, just this kind of a little belt that comes around your body. So those are the home sleep tests that you would do, and let the sleep physician score it, and they'll see if you stop breathing a certain number of times per hour. So we've seen this. This is what kind of a sleep study looks like, that there's these events, and you can see the patient has been, the lower graph is of their body position. So they were going from supine, which is on their back, to the right side, to their left side, back, right side, back, left side. They're all over the place like a rotisserie. And so there just tends to be a lot of disturbance throughout the night. So some of the options that you have, this is the PAP machine. There's a lot of different masks, and we kind of giggle about some of them and what they look like. And then there's now some surgical procedures that can be, this Inspire is actually a hypoglossal nerve stimulator. The hypoglossal nerve is in your tongue. And so they dissect out the hypoglossal nerve up your neck and into your tongue, and then they put a little battery implanted into your chest, kind of like a pacemaker. And then at night you turn on this machine and it darts your tongue forward to open that airway throughout the night. Another surgery that we thought was going to fix people with sleep apnea was to cut out that little punching bag that hangs down. That's called a uvula. So it's a very, very horrific surgery. It's when people come in and have had that surgery, it's called a U-triple-P is what we call it. And they're like, that's the worst sore throat times like 100,000 times, not just 1,000 times. It's a terrible, terrible recovery from that type of surgery. But it has some other issues, because that little punching bag hangs down there for a reason. So if you're drinking something, it kind of comes up and blocks your nose. But if you don't have it, if you take a drink of water, it might come out your nose. So there are some things about it. But years ago, we really thought that that was going to be the cure-all for obstructive sleep apnea, but it didn't turn out that way. Whoops. And then there are 165 different dental devices that are on the market. And that's quite a few devices for me to have to pick from, but I have quite a few that are pretty slim, they're comfortable, easy to wear, easy to use, and they actually do work. Seems a little hard to believe that this little piece of plastic between your teeth can save your life from having a heart attack or a stroke. So it's covered by your insurance if you have Medicare or health insurance. I don't mean to sound like I'm up here as a salesperson, because I really am not, but that's part of one of the questions that a lot of people ask is, well, is it covered by my insurance? And whether it's a CPAP or the sleep study or making you a dental device, that is all considered a medical condition, just like anything else that's a medical condition, and it doesn't fall under the category of dentistry. So that is all I have for this. This is my contact information. If anybody is wanting to send me an email and ask me a question, but I also could then address some questions or let you have a sleepiness scale, or the stop bang questionnaire is up there. I have some pens, I have some appliances if anybody wants to see an appliance, or just general questions that I might or might not be able to answer. Okay? So if there's anybody that has a question, feel free to call it out. Yes, ma'am.
What kind of symptoms would a person experience that might make them wonder about whether or not they had apnea?
Well, usually it's that they aren't getting a good night's rest, that they're tired throughout the day, that they actually might fall asleep unintentionally, that they nap throughout the day, that they don't feel rested and that they've had a good night's rest when they get up in the morning. So that's a few.
I have sleep apnea.
You have sleep apnea?
I do.
And how do you treat it?
What?
How do you treat it?
I use the
Machine.
Okay.
yeah.
A CPAP machine?
Yes.
Okay. And how does that
It
work?
goes
for
over
you?
my nose.
Uh-huh. And so
Yeah.
it blows the air and keeps your airway open.
Yeah.
And so has it changed your life?
Yes.
Yes, I
Somewhat.
bet.
Not a whole lot.
But it has
It was a shock.
some improvement, right?
I had a sleep study done last November,
Mm-hmm.
and the neurologist wanted me to pursue it, So,
Mhm.
yeah. So it took me a long time before I actually got the equipment and started using it, but
Yeah.
it's been a few months now.
Yep. So there's quite a few companies that make CPAP machines, and so in June of 2021 there was a recall of some of the CPAP machines, and so that's made it a very difficult for a lot of patients that are being diagnosed to go into CPAP treatment, because there's a backlog of machines and being able to have the availability, because the other companies didn't expect for the biggest brand name to be recalled. So that's created quite a problem recently. So there's a couple questions.
I have a question, and that is sort of funny. How many of us just took a nap during your presentation? Maybe just a brief one.
Yep.
What percentage can switch from a CPAP over to a appliance?
Well, if you ask me, I would say 100%. Okay, the American Academy of Sleep Medicine puts a label on the severity of sleep apnea: mild, moderate, and severe. So if you have 5 events in an hour, which an event is stopping breathing for 10 seconds or more, and it's always more, 5 times an hour, up to 15 times an hour, that's considered mild. moderate is 15.1 up to 30, and then anything above 30, 30.1 and above, into the hundreds is severe. So the Academy of Sleep Medicine says if you have severe sleep apnea, you should at least try a CPAP. If you have mild to moderate, you could have a choice, the CPAP or a dental device or surgery. So the people that have severe sleep apnea, if they cannot tolerate the CPAP, then they tell them then something is better than nothing, and so you can go and have an oral appliance or a dental device made. And I've treated a lot of patients that have severe sleep apnea, and it isn't as much of the number of times that you stop breathing that is the problem necessarily. We now have found, because again, each year we're learning more and more about this fairly new disease, is it's about the anatomy. And so if your jaw tends to fall back, if you are born with a tiny airway from great-great-grandpa on your mother's side, then you come by it naturally. And so there's ways of, with the oral appliance, to just hold your jaw. It doesn't have to pull you out towards like the parking lot out there. Or you aren't gonna walk around looking like Jay Leno with this big strong chin. It just holds you from falling back, and that's usually the culprit. And so if you have a tongue and a jaw that falls back when you relax, that's the culprit probably 88% of the time. And so that way, I've seen patients over and over and over that can't wear the CPAP, so they've been sent to me to try an oral appliance, and they do just beautifully. So did that answer your question?
Sort of.
Well, could you ask it in a different way? The answer is yes. People can go from CPAP to a dental device. I guess that was a long-winded answer. Sorry. I thought there was a lady in the back. Yeah.
Can you tell me whether restless leg syndrome is connected to sleep apnea?
Yes, ma'am. Well, when we're sleeping, and if we're in one of those three stages of sleep, N1, N2, or N3, our brain is asleep also, but if it notices that you have stopped breathing, then the brain wakes up, not you, eyes open, but your brain wakes up and says, oh my goodness, she's not breathing. So the brain will send a signal to your legs and say, move her leg and let it kick. And that kicking will cause you to not necessarily wake up, but go from one of the sleep stages, like if you are in N3 or in N2, and go to a lighter sleep stage. You don't have to wake up. And so that kicking is to arouse you, is the term we use, to a lighter sleep stage so you can take a breath. And then you'll take a breath. And then the brain will say, uh-oh, she's not breathing again. So we'll say, roll her over, so we see people tossing and turning throughout the night. So that leg kicking, if you have not been diagnosed and you have a lot of events all night, that's usually because the brain is stimulating your legs to move so that you'll take a breath. So when we then take care of your sleep apnea and have it managed either with a CPAP or with a dental device, then we do another study and find out, are your legs still kicking? And if they are still kicking, then the diagnosis can happen that you have restless leg syndrome. Because if we've stopped the kicking because of the sleep apnea, then that was the cause. But if they keep kicking, then we know that it's restless leg syndrome. So it's kind of a basis of elimination. Does that make sense? That you can have it, but we aren't sure which it is or which is the cause. Yes, ma'am.
Is insomnia part of this, or is that a whole different thing?
Insomnia is one of the 90 other sleep issues, but a lot of times people that have sleep apnea also suffer from insomnia, and it's because they keep getting woken up throughout the night and then sometimes can't get back to sleep. So insomnia usually is not just that you can't get to sleep, but also if you get to sleep eventually, then if you're awakened throughout the night, you can't get back to sleep either. And so sometimes they can have a correlation because of the adrenaline that hits your body to wake you up to take a breath or kicking your leg or things like that. So yes, there can be a correlation. What other burning questions does anybody have? So one thing that I probably should also mention that I didn't is that frequent urination at night tends to be a common result of sleep apnea. It doesn't have to be, but we often see that the brain, when it's not getting in the lungs or not getting enough oxygen, that our body actually creates a diuretic, which then turns the kidneys on and says we need to eliminate extra urine because it's toxic in circulating in our body. And so when my patients come and talk to me, especially my male patients, they're like, no, don't talk to me about nighttime urination because it's a prostate problem or a bladder problem or whatever excuse that they use. And also some women say, no, I've had a bunch of kids and so I've always had a bladder issue. Well, it turns out that once I get them in their appliance and they're sleeping, they'll come in and say, oh my goodness, how is this connected to my bladder? Because I don't have to get up and pee as frequently. So when people are sleeping and having to get up 3 and 4 times a night, all of a sudden they're only getting up 1 time a night. Well, guess what? It has to do with your sleep apnea and having it treated. Unfortunately though, my urology friends have not really embraced learning as much as I think they should about sleep apnea, and so they keep trying different drugs for you to take, and sometimes as a last-ditch effort, they will say, oh, maybe I should send you for a sleep study, and sure enough, you have sleep apnea. So I think that that's unfortunate. But the same thing happens with children. So if a little kid that's 5 or 6 years old has really big tonsils that are touching and blocking the airway, they could have sleep apnea, even if it's just 1 or 2 times an hour. And sometimes the problem is that at age 5 or 6, they're getting into that deepest sleep of N3, and they don't wake themselves up good enough to notice that they need to urinate, and so they are bedwetting. So unfortunately, people think that that's a urology problem, where just having the tonsils out cures the problem. So there's some really interesting things that people just have no idea the cause and effect, or what things go together to actually cause an issue that might not be really related or unusually not even considered part of a problem with sleeping.
Well, we appreciate you coming to Cedar Field and spending the afternoon with us. I'm going to turn the light on so you all can go look at the information over here, but thank you so much for coming.
You're welcome. Thank you for having me.
Sign me up.